Dr. Aadithreya. So he'll be telling us a few things about the KLex procedure, because of which I had deliberately avoided it. He's an expert in that field. He's from Umai Clinic.
So, morning everybody. Thank you, Swapna ma'am, for inviting me to your course. It's a real pleasure to be here. So, I'm going to speak about KLex very quickly in 8 minutes. So, let's discuss why transition to lenticle extraction first and how to transition effectively. So, as we know, LASIK is a proven modality of laser correction. But why should you even consider transferring to SMILE or any other form of lenticle extraction? So as we know, the main advantages in doing a lenticle extraction are as follows. One is there's no flap. We do all of the procedures through a 2 mm incision that preserves the subbasal nerve plexus, so there's less dry eye, better biomechanical stability, and the results are very accurate. But there's one thing that people miss when comparing SMILE versus LASIK. That's to do with the excimer ablation, which has an inducing cosine effect. So let's discuss this effect first. So when you do an excimer laser treatment, whether it be LASIK or PRK, what we have to understand is the excimer laser is delivered ultimately via mirrors. So when you do this treatment on a prolate cornea, which is a cornea which is not touched yet, the central zone is treated more than the peripheral zone. So this leads to a cosine effect where the peripheral zone is not as well as ablated as the central zone. So we look at this diagram here. This is a diagram of an excimer laser performing a treatment on a normal prolate shaped cornea. So when the beams first hits the center, it's a very well spaced spot. There's no cosine effect. But as the treatment goes further towards the peripheral spots are larger than the central spots. So this leads to a sort of like an uneven treatment zone. So the effective central treated zone is much tighter than the transition zone. So this is what gives rise to spherical aberration, because the center is treated more than the periphery, and this effect compounds when you have higher degrees of myopia when you're treating. So this is why some people, when you do a LASIK and they have a high power correction, they complain of starburst, glare and halos. It's precisely because of this effect. When you do lenticle extraction, this effect is totally not there because it's a flat applanation. We use a contact glass to applanate the cornea, and this gives rise to a very even treatment zone right from the center to the periphery. So, in lenticle extraction, whether you're treating a -1 or you're treating a -10, the time taken is the same. It's about 8 seconds. Whereas when you do a LASIK for a -1, it's maybe about 5 seconds or so. With -10, it takes almost 30 seconds. So that's the real advantage that not many people discuss about. The other things we already know, it's a 2.5 mm incision compared to a 24 mm cut in LASIK, and that's why this preserves the corneal integrity, better biomechanical stability, and much lesser dry eye. So I just very recently completed a study in my center of 1,600 eyes of Smile Pro on the Visumax 800, and the results are outstanding. So this is right from minus zero point -0.5 to -10 with up to -4 cylinder. 99% of eyes achieve 6.6. Stability is very good, no loss of lines. 99% of eyes are within half a diopter of the refractive accuracy. Cylinder correction is also excellent, where the mean rotation of cylinder is within 5 degrees in at least 86% of eyes. So let's now move to the standard operating procedure. Now, if you're convinced about SMILE, how do you actually go about and perform the procedure in a standardized way? The most important step, I would say, is in the ocular surface preparation, where you have to prepare the surface and make it perfectly wet. It should not be too wet, it should not be too dry. So this is how we do it here. Ensure that the lashes are kept out of the way. You can use a tape to keep it out of the way, or you can use a flange speculum if you want to skip the tape also. Just very gently, just very gently irrigate the surface. So the cornea has to have an even film of saline, whereas the conjunctiva has to be perfectly dry. So this is what I do. Just one swipe on the cornea just to make it evenly wet. But if you make it too dry, it will have a lot of black spots. Docking is of paramount importance. In the newer machines, you can dock exactly on the corneal vertex. So the older machine on the Visumax and the other lenticle platforms, you dock only on the pupil center. Whereas in the Visumax 800, you have an accurate alignment protocol which allows you to dock exactly on the corneal vertex, and it tells you how far you are from the corneal vertex and helps you identify where exactly the treatment center should be. And that's it, you have perfect centration. Cyclic torsion compensation is now also automated in the Visumax. Here I'm using the Visumax platform and doing the cyclic torsion compensation. After docking, you can align the reticule with the marks that you have made in the slit lamp in the 0180. So any amount of cyclic torsion can be very easily compensated. As of 6 months ago, even this has been updated where you just have to dock and it auto aligns according to the iris marks. If you have the IOL master, this can be done. So this part is also very well taken care of. Energy settings, you have to standardize. So the appropriate energy settings depends upon machine to machine. So some machines it has to be higher, some machines it has to be lower. Ideally, I would say start with the energy settings that the company gives you and then gradually bring it down because the lower the energy settings, the faster the recovery. But as a beginner, keep it a little higher, keep the spots a little closer so dissection is easy. But as you keep getting more experienced, you can increase the spot spacing, lower the energy, so you will have faster recovery on day one. So this is what we have to see in an ideal energy pattern. So my machine is optimized over the course of the last 3 years, and we figured out what exactly the ideal energy pattern is. So once you dock and apply and give applanation, you can see the bubble patterns which are about to appear here. They'll be very even. There's no black spots, no OBL, nothing. It's a perfect energy pattern. This is ideally what you should get in every single case. I'm going to overshoot by another 2-3 minutes because of my instruction video. Okay, so how do you do the dissection? So we have to have an ideal dissection protocol to ensure that we're able to get the lenticule out in every single case. So here, what we do here is I open up the incision and I use this tip to lift up on the incision edge. So you don't go by mistake into the posterior edge. Ideally, we must open up the anterior edge very firmly first, and only then we should attempt to go under the lenticule and find the posterior plane. So when you do this, you will find that the bubbles will decompress. So there's an animation here. You take the tip, lift up on the incision edge, and find the superior pocket. And once you do that, you make a very small entry into the inferior pocket, so you identify where the correct planes are. So this is superior pocket. I'm lifting up here. I'm just finding the superior plane. So I move it end to end. So that's the superior edge. And now you can touch the edge of the lenticule. Just scratch it a little bit, you will find the resistance and make a very small entry into the inferior plane. Don't make the inferior plane entry too large in the first attempt, because if you do that, you might enter by mistake into the posterior plane and do a posterior dissection, which is going to be very difficult to retrieve the lenticule then. So again, you can just check twice, see if the planes are correct. So that's the superior plane, and under it is the inferior plane. Superior dissection, what you have to do is you have to go from end to end. So in the superior dissection, you have to dissect to the superior bias. Here, you have to go right up to the cap edge, but when you're doing the inferior dissection, stay within the center of the lenticule and leave some anchors of tissue there so that the lenticule does not fold over. So we'll go to the superior dissection first now. So as you see here, when you're dissecting superiorly, you go right up to the edge of the cap. And you have to move like a windshield wiper. Don't move from side to side. You have to move from like a windshield wiper, pivoting within the incision, so you ensure you don't tear the cap at all. Now, here comes the catch. When you're doing the inferior dissection, you'll be tempted to go all the way to the end. Do not do that. Go to the inferior dissection and only stay within the lenticule center. Don't move out of the edge of the lenticule. We must keep the edges of the lenticule intact in this setting. So as you see here, the edge of the lenticule is still intact, but the center is all fully dissected. Once you've done that, you can start to separate the edge, but keep anchors of tissue intact so the lenticule does not fold over. If you just do it in one sweeping maneuver, the lenticule will fold over and you will not be able to find it so easily. So what you do here is, in the final step, ensure that there are some anchors of tissue intact, and then you can very gently do the edge dissection in one half. So I'm doing it now from the 12 to 6, and then I'm leaving an uncut edge there on purpose. So there to anchor the lenticule, and then do it in the other half. So once you've done that, as you can see, the edges are now separating, but the lenticule is not folded over. So because of this, you will have a nice fully separated lenticule which is not folded over and can be very easily extracted. So that's the final separation. And after this, as you can see, the lenticle will just come out very easily with no resistance at all. So that's the end of it. It's a fully intact lenticule and can be very gently extracted out with forceps without any difficulty. So to conclude, you have to adopt a repeatable technique for lenticle dissection to perform every case. And also in doing it, pay attention to the proprioceptive feedback on your fingertips, so as you know where the resistance is during the lenticle dissection. And ocular surface preparation and energy optimization come first. Only if you get that right will lenticle separation be easy. Thank you for your attention.